Dr. Chinoperekwei to share your screen. Dr. Chinoperekwei, may you start sharing your screen before I introduce your profile? Your first slide.
Thank you so much, Dr. Grant.
All right.
I'm waiting for the host. Oh, yeah.
Okay, that's all right. So I think you should be able to share your screen. So Dr. Anesu Isabel Chinoperekwei is one of us. She's a specialist psychiatrist, a graduate from the University of Zimbabwe with Bachelor of Medicine and Bachelor of Surgery degrees, diploma in mental health, and also a Master of Medicine degree in psychiatry. She runs a private practice in Milton Park, Harare, which is called the Serenity Mind Center. She's married with 3 children, and she's very passionate about improving the mental health of our society through raising awareness, improving acceptance of those different from us, and with efforts to reduce stigma. So Dr. Chinoperekwei, you please take over the platform and make your presentation.
All right. Thank you very much, everyone. It's really a pleasure to be part of this forum. I have been privy to a lot of very interesting discussions, and I must say I have learned 1 or 2 surgical approaches to endometriosis, and you guys, you really do quite a lot, and I appreciate what you do. Thank you so much for inviting me once again, and thank you so much to all the speakers who spoke before me. They have helped to make my part of the presentation easier. Thank you, Dr. Ngwaru. You did touch on some very important things that I may comment on in my presentation. Thank you. So I have been introduced. My portfolio is not really as large as those of my predecessors, but I hope you can learn something as much as I have learned from you. So today I'm going to be talking about the link between endometriosis and mental health. So you find that the symptoms of endometriosis, they often affect psychological and social functioning of patients. And this alteration or disruption in function affects all aspects of their lives, including their social relationships, their sexuality, as well as their mental health. Sorry. So what are these mental health conditions that are ordinarily or normally associated with endometriosis? These include, amongst many, anxiety disorders, including phobias, depression, suicide, somatic symptom disorder, and what I just threw in there as an afterthought, what we call alexithymia. So what are the statistics or the numbers rather concerning these mental health conditions? So you find that the prevalence of anxiety symptoms in a certain study, it was found to be as high as 31.8% amongst people who were being followed up for endometriosis, and that prevalence is actually almost 3 times higher as compared to women without endometriosis. And then in terms of depression, the prevalence of depressive symptoms in women with endometriosis was found to be almost 30% compared to those without endometriosis. And then the prevalence or the numbers concerning self-harm. By self-harm, we are including harm which does not lead to suicide and also that which leads to suicide. So that collective figure of self-harm showed that there's a 2 to 3 times more likely risk of having or taking part in self-harm in those with endometriosis compared to women without. Okay, and so and then in another study, they were trying to follow up women with endometriosis, and they found quite a very high figure of depression and anxiety. In their study, they found as many as 86% of women with depressive symptoms and as many as 87% of women with anxiety symptoms. And they noted that the occurrence of either anxiety or depression was not necessarily associated with the stage of the endometriosis, but most importantly, it was associated with the degree or level of the pain from that condition. Okay, so what are the psychosocial correlates that sort of predispose women with endometriosis to mental health illnesses? So amongst the symptoms that we have been learning of throughout the day, we have menstrual irregularities, chronic pelvic pain, dyspareunia, infertility, dysmenorrhea, dyschezia, dysuria, amongst a list of many. So you find that with menstrual irregularities, women experience a disruption in routine and planning because they cannot necessarily plan when they are going to have certain events, which may be sort of restrictive in terms of their menstrual cycle. And sometimes people become afraid of going to certain parties or certain social events for fear that is an unexpected heavy flow of menses may just start and it disrupts their way of life. So this results in quite a lot of frustrations and feelings of helplessness because they do not know what they need to do or how these symptoms can be made better. And then you also find that one of the major symptoms of endometriosis is the presence of chronic pelvic pain, and in this and because of it, women experience high levels of stress, which then result in a lot of neurobiological alterations, which then trigger many mental illnesses, and we'll talk about these as we progress. But however, most importantly, there is an inability to participate in normal activities of life, including occupational function. So you find that because many women may call off sick for quite a significant portion of their working year or their working month, it may result in job losses, and it also results in restrictions in other areas of life. And then we go on to dyspareunia, another very common presentation of endometriosis, and Dr. Ngwaru has done justice to that, and I will not go a lot into it, but I will just mention that dyspareunia results in a lot of dissolution of marital unions, as well as resulting in feelings of inadequacy and poor self-image because of failure to meet societal as well as family role obligations as a partner. And of course, the big one, infertility, especially in our African context, whereby having a biological child is looked on with a lot of emphasis, both from the spouse or partner and as well as from the family and the community. This stress or this failure to achieve a pregnancy actually results in chronic stress and leads to many mental health conditions. And then there's dysmenorrhea, again resulting in helplessness and poor self-esteem, as well as being poorly understood by peers and significant others. So you find that even amongst the women themselves, many women do not understand this condition unless if they've had it. So people tend to minimize symptoms and sort of diminish or undermine the symptoms that a colleague or a peer is presenting with, because they will be saying that I'm also a woman and I don't have that level of pain. Maybe you are faking it. Maybe there's a secondary gain to it, etc. So that inability to be understood by peers and significant others, it places a lot of stress on the sufferers of endometriosis, and it makes them feel inadequate and constantly questioning themselves as to what is wrong with their bodies and why their bodies seem to be giving up on them. And then, of course, dyschezia, dysuria, urinating and defecating are part of our everyday lives. One would not be normal if they are not going to the toilet. So I just want us to imagine, to put ourselves in the shoes of someone who, every time that they have to go to the toilet, they experience so much pain, debilitating pain, such that they actually become sort of traumatized or excessively worried about a normal bowel or bladder motion. That is really quite worrisome. Okay, and then I just wanted to highlight that endometriosis related pain, but not the disease itself, it seems to increase the prevalence of depression. By this, I mean that I know we have been learning a lot about the various stages of endometriosis in terms of depth of penetration, I think, of the that abnormal stroma, if I may say, into the surrounding tissues. And I'm sure that's how you grade it. So it is not the grade or the level of the stage of endometriosis which then determines the likelihood of developing depression, but rather it is the severity of the pain. And you find that with endometriosis, even people with maybe a stage 1 disease, if I may say so, may actually experience a severe debilitating pain as compared to someone with stage, should I say stage 4 or a higher stage of endometriosis. Okay. However, when it comes to infertility and when it comes to dyspareunia, as Dr. Ngwaru has said, somehow the stage of the endometriosis then is significantly related to the level or to the incidence of depression. So I hope you get the difference between the two. And then we go on to the biological correlates or the neurobiological correlates that link mental health disorders and endometriosis. So the gynecologists are better at this sort of thing, but we understand that endometriosis usually results in higher levels of circulating estrogen in women. And then, as we all know, those hormonal imbalances or hormonal shifts, they affect mood and may result in feelings of anger, irritability, and frustration. So whilst a woman may not have a diagnosed depression because they are not meeting the clinical criteria, or they may not have anxiety disorder because they are not meeting the clinical criterion, they may actually be seen to experience just irritability. You know, those women that we see who are always in quotes cheeky, who are always frustrated, who are easily angered. That can actually be as a result of these disruptions in the estrogen levels. Okay, and then we go on to talk of the HPA, hypothalamus pituitary adrenal axis, and we know that cortisol is an important hormone which is released during periods of stress. It is an important and necessary hormone because it prepares our bodies for fight, for flight. You know, it really gears us up to action. But that benefit is only good in the short term if there is prolonged or unremitting stress levels. You then get prolonged levels of elevated cortisol circulating inside the body, and this then also affects the immune response, the inflammation in the body, and well, more inflammation can ultimately result in more pain, as in the perception of pain. So the same stimulus which maybe would have caused a grade 2 pain, just because we have high levels of circulating cortisol, that same level of pain may become a grade 7 pain. So now, speaking of chronic pain, which is one of the major hallmarks of endometriosis, you find that the nerves in the spinal cord, the brainstem, and the brain itself, they become more sensitive to painful stimuli over time, and that is called central sensitization. And painful periods over many years then contribute to central sensitization. And as I have said, things that used to be only mildly painful, they can become very painful. And that type of pain, that central pain, does not respond to traditional painkillers. And in terms of that pain, the sensitization, central sensitization theory of pain and the link to depression, we all know that certain monoamines are really important in terms of the etiology of most mental health conditions. And these include dopamine, serotonin, and noradrenaline. So you find that with chronic pain, there is a significant damage to the dopaminergic activity in the limbic midbrain area. That is according to a certain study. And now, now that there is that damage to the dopaminergic area, it means the levels of circulating dopamine levels in the brain will become depleted. And that in itself can cause depression. And at the same time, that depleted dopamine levels also result in increased sensitivity to pain. So really, we can see that there is a link between the monoamines, which in their absence cause depression, and which also in their absence result in heightened pain sensitivity. And then there's also this the glutamate theory, and it says that we all know that glutamate is the major excitatory neurotransmitter of the brain, and increased glutamatergic activity results in heightened pain sensitivity. And the thing which then dampens this glutamatergic activity are the GABA or GABAergic neuronal activity. So you find that in people with depression and chronic pain syndromes, they have increased levels of glutamatergic activity in the absence of normal GABAergic activity. And then, well, the list is endless, really. There's also this theory of the brain-derived neurotrophic factor, which is helpful in terms of allowing synaptic neuroplasticity. So when we're talking of neuroplasticity, we mean that our brains, in order for us to function, they need to be constantly adapting to the stressors and to the things that they are subjected to. So that is neuronal neuroplasticity. So brain-derived neurotrophic factor is an important aspect of this brain neuroplasticity. And when you have too little of it, there is a maladaptation of these synapses, and you actually find for certain studies which have been done, they found that the prefrontal cortex, the hippocampus, and other depression-related structures are found to have a reduced level of brain-derived neurotrophic factor. And this depletion is also seen in chronic pain syndromes, including endometriosis. And then inflammation, whatever the cause of the inflammation, and of which endometriosis, it sort of speaks about a state of continued inflammation of those endometriomas, or those ectopic endometrial tissue that then can result in disruptions to the blood-brain barrier, which will then result in changes in neurotransmitter levels inside the brain, thus resulting in depression, anxiety, and other mental health conditions. And now, as we continue to learn about this endometriosis issue, you also find that there are certain treatments that can be used to try to mitigate or to lessen the pain of endometriosis. And amongst them, from what I've also learned from colleagues during the day, they may try to use gonadotropin releasing hormone agonists. I don't know how effective they are, but I do know that sometimes these agonists actually result or actually precipitate anxiety and depression. So one can get depression and the anxiety as an iatrogenic result of as a result of seeking treatment. That's number one. And number two, one can get depression and anxiety as a result of the endometriosis itself. Okay, so you'll find that for this reason, when people are treating endometriosis, it is really important to treat the person as a whole and not just as a pelvis. Okay, to recognize that a human being has an emotional component, a physical component, by which is usually the pelvis in this case, and a spiritual component. And that for us to really achieve good results in terms of treatment, we also need to target their emotional or psychiatric problems and to really think of the psychiatric implications of the treatment that we then choose to use for our patients. In summary, the neurobiological link between mental health and endometriosis is that injury, sensory pathways of the body, pains have been shown have shown that the same brain regions involved in mood management, including all these things, the prefrontal cortex, insular cortex, thalamus, etc. The same things have also been found in depression. Okay, and then chronic pain and depression may be based on common neuroplasticity mechanism changes, which I've just spoken of, and these are potentially important routes for onset and aggravation of chronic pain and depression. By this, we mean that the more pain one experiences, or the less we try to mitigate that pain, then the worse their depressive symptoms or anxiety symptoms or somatic illness symptom disorders become. In the same vein, the less we treat their depression and anxiety, the more perceived pain they then get. So it is important to understand that dual connection and to treat both. Okay, and the factors which may affect the severity of the mental health symptoms that we've spoken of, they include, amongst many, the length of time one has had symptoms. And from the discussions, I have learned that one can take as many as 7 years or as much as 10 years before the correct diagnosis of endometriosis is made. And we can imagine what it means to have chronic pain and not knowing what its cause is. That in itself has a great implication in terms of severity of the mental symptoms if and when they do okay. And then the way one was told about the diagnosis, as I've said, the human being or that female patient that you then see with endometriosis, she is not just a pelvic organ. She is an emotional being, a spiritual being, a physical being. And the way we break the news about this condition, the way we explain it, it has a bearing on any mental health symptoms that they have. And also the information that we tend to give patients as diagnosis. How sensitive are we when we are giving this diagnosis to our patients? Do we take time to see them, or are they just a statistic in a line who are taking too much of our time, asking too many questions when we've got the next patient to see? So it's really important to ask ourselves and to reflect every time that we have this condition that we have a patient with this condition, to really sit down with them and explain to them what it means, what it does not mean, and how their lives can be made better. And then the severity of the symptoms, it also is also dependent on the treatment options available. During this very impressive seminar, I have learned that the approaches, they start from just non-surgical or medical treatments, going on to surgical treatments, depending on severity and depending on certain things that you as gynecologists see. But the treatment options that you may want to offer to a patient, one, they may not afford them. Maybe it's surgery and they can't afford it. That's number one. Or number two, they want surgery, but maybe you are advocating for a medical management or just a pharmacological management of their symptoms. So that can result in frustration to the sufferer. And so again, it's really important to explain to them the treatment options that are available and why you are motivating them for one type of treatment versus the other. And of course, there are the personal factors which affect how patients then, how severe the patient's symptom get to be, and that is the type of personality. There are those who are generally anxious, generally worried people. That's their personality. And whatever illness it is that they are diagnosed with, they are more likely to then have severe reactions to it, and perhaps also a more severe mental health illness. And one of the most important things, the level of psychosocial support available. So yes, whilst the clinician needs to support his or her patient, it is also important for us to identify the important others in that person's life. And usually if they are married, as I've said, there will be usually a lot of conflicts between the partner, maybe because of infertility, maybe because of dyspareunia and so forth. So to really try to make sure that when you have your patient in front of you, you sort of try to get an understanding of the level of their support, the level of intimacy of their significant others, and also to try to incorporate them during the treatment plan. Okay. And also, lastly but not least, the impact of the disease on lifestyle, socializing, and plans for the future is a significant effect on the severity of the mental health symptoms. So, for example, let's say one wants to be a travel agent, going all over the place, always on the go. Those symptoms of endometriosis actually are crippling and debilitating, and they limit them in terms of that freedom to follow certain career paths. And that in itself, those restrictions, they add on to the stress that one has, and then they then affect the severity of the mental health problem that then comes about. And then, of course, our society has many myths on mental health issues. Even amongst us as clinicians, I know we have many myths surrounding mental health. And however, these myths and misconceptions, they make it worse for people or sufferers of endometriosis to be better for it in terms of their mental health in life. And it really takes a big toll on them. And as I've said, those feelings of being misunderstood or unheard, they really set patients back. Okay, so in conclusion, I am saying that with this diagnosis of endometriosis, it's not just a physical diagnosis or a diagnosis affecting the physical aspect of one's health, but it also affects the emotional and psychological and social health of a woman. And in our approach, whatever it is, be it its diagnosis, be it at breaking the news of the diagnosis, be it at the long-term management of the patient, let us be empathetic in our approach. And let's learn to listen, and then let us encourage a multidisciplinary approach. The human being is more than just a mass of pelvis or of uterus. And let us always be cognizant of that. And then it's also important to put up more awareness, to dispel myths, and to encourage support. Thank you very much for your time. This is the end of my presentation. Thank you.
Thank you, Anesu, for such an insightful and passionate presentation. I think it's one of those that takes us back to several years in medical school when we were told that we should now actually be adopting biopsychosocial models over medical models when it comes to patient care, where we have to look at the whole patient holistically instead of just focusing on their presenting complaints. And so your presentation and Dr. Ngwaru's presentation really do justice to this. The first question, which was directed at Dr. Ngwaru, but which you can also answer is, are there any sex therapists in Zimbabwe where we can actually refer patients to when they have these psychosexual problems?
Okay, thank you so much for that. I do not know, at the moment, I do not know of someone with a subspecialty in sex therapy, but there are many psychologists who can offer that therapy if anyone wants it. I think I can provide a list maybe to your organization, and then you can always cascade it to whoever needs it.
That's all right. Thank you very much. Do we have any other questions for Dr. Chinoperekwei? All right. I see no raised hands. I see no questions in the chat box. This has been a very empowering segment. We have learned a lot on the medical and surgical management options of patients with endometriosis from Dr. Mzamiri all the way from New Zealand. We have also learned so much about the endometrioma from Prof. Fernandez. Thank you very much, Prof, for your time. And then we had Dr. Ngwaru talking about psychosexual dysfunction in patients with endometriosis. And lastly, we have just heard from Dr. Chinoperekwei, who took us through the mental health complex in patients with endometriosis. I think this has been very empowering for us as clinicians, not just as gynecologists, but also to the other clinicians, the GPs and others who are actually on this platform. So allow me to thank the presenters. We have reached the end of this segment. We have reached the end of this segment. During the break, we're just going to play a testimonial audio from one of the patients who suffered from endometriosis, just to show how much of a distressing condition it can actually be. But otherwise, we are now going on a lunch break for 1 hour, and we'll be back at 2 o'clock for the next set of presentations. Thank you very much for being with us through the whole morning into the early afternoon. Enjoy your lunch, and let's be back at 2 o'clock.